All right, perhaps we'll get started then. Hello, everyone. I'm Jeremy Chalk. I'm a public health registrar working with the NACCHO Cancer team, and I'd like to welcome everyone to our second webinar for the National Lung Cancer Screening Program on shared decision making for Aboriginal and Torres Strait Islander people. So it's great to see a lot of you joining us today from both the ACCHO sector and outside the sector. We're very grateful to everyone for taking the time out of their day to join us. So of course, I'd like to begin by acknowledging the traditional custodians of the lands from which we're all joining today. For myself, I'm very privileged to live and work on the lands of the Wurundjeri Woi-wurrung people in Naarm. I'd like to pay my respects to elders past and present and extend those respects to any Aboriginal and Torres Strait Islander colleagues joining us today. So a bit of housekeeping to begin with. Please keep your microphones muted during the presentation, although I think the webinar function might do that for you, but just in case to check. We will have, there's a Q&A function that you can use to ask questions during the webinar, and do encourage you to do so if you have any questions. We should have some time at the end to address questions as well. There's also the chat function that you can use for any comments or to interact with each other, and we'll pop some links to resources in there towards the end of the webinar as well. And just to let everyone know that today's webinar is being recorded, and the recording will be made available afterwards. And just also a thank you to the Australian Government Department of Health, Disability and Ageing for funding this webinar. So a bit of an overview of what we'll be covering today. I'll begin by providing a brief overview of the screening pathway. We're then very lucky to be joined by Associate Professor Lisa Wap from Yadura Walani, the National Centre for Aboriginal and Torres Strait Islander Wellbeing Research at Australian National University, who will take us through the brilliant work her and her team have done in co-designing a model and toolkit to assist healthcare providers and community members in engaging with shared decision-making for lung screening. Sarah McDermott from our NACCHO Cancer team will then update you all on some of the resources that are currently available and more that are coming soon. And then, as mentioned, we'll have some time for questions at the end. So just to recap, and many of you are probably aware of this by now, but screening for the National Lung Cancer Screening Program will use a low-dose CT scan of the chest. And so for people who are eligible for the program, they can receive this every 2 years, which is the standard sort of 2-yearly minimal pathway. But they can also access follow-up CT scans more frequently if needed. And I'll go into a bit more detail on that in a moment. Participants can access screening through existing fixed CT scanner infrastructure, so in participating public and private radiology practices. However, mobile screening will also be delivered through Heart of Australia under a contract with the Australian government. And this will be available in some rural and remote areas. So the first truck will go to the top of Western Australia, including the Kimberley and Pilbara regions from November this year. With that said, Heart of Australia will also be taking one of their existing trucks that operates in Queensland at the moment. They'll be taking that over to the top of WA in August to help build aware of lung screening and potentially do some opportunistic screening whilst they're there. So I'll now go through a simplified version of the screening and assessment pathway just to illustrate the key elements that map the participant journey. So beginning with promotion and awareness in the top left to raise awareness of the program in communities. And Sarah will speak to that a bit more at the end. It then lists the eligibility criteria, which I'm sure many of you have seen by now. But people are eligible for the program if they are aged 50 to 70 years old, if they currently smoke or quit within the past 10 years, if they have a cigarette smoking history of 30 or more pack years and have no signs or symptoms that suggest lung cancer. So it then moves on to program entry. So this is around identification of potentially eligible participants and inviting them to discuss lung screening and for an eligibility assessment. It then moves on to enrolment and shared decision making. So once eligibility has been confirmed, the client needs to be checked if they are suitable to have a low-dose CT scan, and then enter into a process of shared decision making to ensure they're making an informed choice of whether to participate. And of course, that's what we'll be primarily talking about today. If they'd like to participate, then you need to provide them with a request form for the low-dose CT scan, and they can book themselves in at a participating radiology service to go and have the scan. So moving on to screening there, that's them going on over to have the scan. Once they've had this, it will be reviewed by a radiologist who will provide a structured radiology report detailing the findings of any nodules and of any additional findings. And this will be sent to the practitioner who requested the scan through sort of business as usual communication from the service provider, but it will also be uploaded to the National Cancer Screening Register, or the NCSR, so participants' results can be viewed on there as well. And you can see in the top right there, these are the various risk ratings the radiologist will use to categorize the findings. So it runs from very low risk up to very high risk. Very low risk is the lowest possible risk rating any scan can get. For these, they essentially, no follow-up scan is needed within the 2-year period. They just need to have their sort of regular 2-yearly scan in 2 years' time. And then for low risk, low to moderate risk, and moderate risk, for these ones, a nodule has been identified that just needs to be monitored a bit more closely. So for low risk, they'll need to return for another scan in 1 year. For low to moderate risk, they'll need a repeat scan in 6 months. And then moderate risk, they'll need a repeat scan in 3 months. And that's just to reassess the nodule, check for any changes, concerning changes or growth. And then for high risk and very high risk, these need to be referred to a respiratory physician straight away, and ideally one that's linked to a cancer multidisciplinary team. And then, of course, there may be some actionable incidental findings or additional findings on the scan that also may need to be managed. These will all be included in the structured report from the radiologist. So in terms of how results will be communicated to the participant, so for the very low risk, that lowest risk rating finding, the National Cancer Screening Register will notify the participant of that result and that they just need to have their next scan in 2 years' time. But for any findings where further action is needed, so from low risk to very high risk, and for actionable additional findings, the NCSR will just let the participant know that their results are ready. It won't include the results in their communication, and it will ask them to see their healthcare provider to discuss the results and any next steps. And then at the bottom is highlighting the importance of offering smoking cessation support to the client at various points of contact with them throughout the pathway. And a quick and easy way to do that is using the Ask, Advise, Help model. And also just, of course, want to acknowledge that while this program is specific to lung cancer, we know ARCHO's holistic model of care may extend beyond this, and points along this pathway will represent opportunities to ensure clients have had their health checks, GP management plans, if that's appropriate, ensuring they have their vaccinations up to date, and any other element that might contribute to their overall lung health or general health and well-being. Okay, I'll now hand over to Lisa Watt to take us through shared decision making for lung screening. Thanks, Lisa.
Great, thanks, Jeremy, so much, and nice to see so many of you online. So my job is really to take us through shared decision making and how we came to do this work. For those who don't know me, I'm a researcher here at Yardja Rawlani, one of the associate directors of research, and was privileged to lead some of this work with some of our staff here in the centre. I'm a Gumugal Wagadagan person from Mabiag Island. My family's from Zedekes, but I was born and raised on Walgorooka Bindal country up in Townsville, and now living and working and delivering this webinar with you all today here on Ngunnawal Ngambri country. So I thought we just sort of start right back at the beginning. So this was a piece of work that Yajrawani was subcontracted to deliver through the University of Melbourne, but to Cancer Australia. And another part of the piece of work was really about the consultations with Aboriginal and Torres Strait Islander people into the development of the program guidelines, which of course are now published. And the second part of that, but really sort of was iterative and formed all of it, was to develop a shared decision-making prototype or a written prototype that could be used, developed by MOB, for MOB, that could be provided back to Cancer Australia and to NACCHO to develop into the resources that we'll present today. So I thought I would walk through just a brief summary of the process of the consultations, the sort of 4 different phases we went through, and a high-level overview of those resources. But I thought I would just take us back a little bit to talk about what is shared decision making. It's certainly somewhat a bit of a hot topic at the moment. Really, it's something that can happen fairly organically in some settings, but can be the thing that skips out a lot, particularly in healthcare interactions. It's essentially meant to be a collaborative process where both a clinician and an individual help to make a decision together. But of course, we know that different elements play out, including, time that you get with the clinician, the relationship with the clinician, and people's different worldviews and how they make decisions. So particularly for MOB, where they like to make kind of a collective decision, it might not necessarily be with just a clinician, or actually if the clinician's involved at all. The idea is that it would build trust, satisfaction, engagement, and people really have that kind of informed consent whilst they go through the process and have that ownership over their decision. Particularly when it comes to shared decision making, they talk about some particular elements. Some is about knowing all the choices available, and acknowledging that a decision needs to be made, what options are on the table for this person or not, the different pathways, where it would take them. Obviously, the idea of deliberation, and then coming together to make a decision. So essentially, and really simply put, pros and cons of different available options. So numerous international studies have shown that a shared decision-making really enhances the uptake of lung cancer screening, and has been shown to encourage eligible lung cancer screening patients to proceed through to the lung cancer, to the screening stage, so through to the low-dose CT. Research again has shown that shared decision-making reduces that decisional conflict for patients, so it leads them to feeling better informed about the risks, the benefits of lung cancer screening, and kind of what they've got ahead of them. And really the important element of the process is about the need for clear engagement, simple information, so people can make that decision, particularly when something's so new like lung cancer screening. So our approach to developing the lung cancer screening, the shared decision making for lung cancer screening, was quite iterative. Essentially, we founded our intention of developing this prototype by foregrounding Indigenous sovereignty of Aboriginal and Torres Strait Islander people as key architects and strategists of their own health. So they are the best people, best placed to make decisions about their own health. Its purpose is to attend to the sort of power dynamics between health professionals and Aboriginal and Torres Strait Islander people to support that safe and informed decision. And I've just got up here on the slide some of the 7 principles of how we approached this work. And these really came about in the early phases of consultation with Aboriginal and Torres Strait Islander people, when we asked MOB, well, what is shared decision making to you? What are the important things that you need to know? By who, when, at what time, those sorts of kind of fundamentals. So things that came out were that communication information was safe, culturally safe, that it wasn't stigmatizing language, particularly around people who smoke, noting that it's an addictive product, to avoid fear-based language, something that is quite prevalent in other shared decision-making or decision aid tools in lung cancer screening in other trials across the world. To be a flexible approach so that not everyone has to go through the same pathway and that yarn might take a different approach. To provide information via multiple and layered modes of communication. So for this, we've developed the written prototype and it's been developed into a booklet, but noting that it might need to be adapted for other types of communication, whether that be a short video, etc. That it provided opportunity. So the process of a shared decision making provided opportunity for patients or potential participants and family to process information and ask questions. And that it was easy to read, there were pictures, and people could see, mob could see themselves reflected in it. So that was a really key thing. So there's sort of the kind of underlying principles of our approach. I won't get too bogged down in the detail of how the prototype came to be, because I'm just keen to show it to you all. But I think it's important just to say that it wasn't something that was just developed in my office. We did existing literature scopes around what literature existed around shared decision making or decision aid tools, particularly in an Indigenous context, and looked specifically for lung cancer screening, but also a little bit outside. We summarised previous consultations with Aboriginal and Torres Strait Islander people that myself and another colleague, Claire Nightingale, had been involved in prior to the lung cancer screening program getting to this stage. So this was done a few years ago when we were thinking about the implementation factors, and we talked to lots of mob at that time as well. And we also ran some focus groups with Aboriginal and Torres Strait Islander people. And we did this in various ways, but really at that point, it was just to ask what is important to focus on to inform a decision, in what way, in what format, by whom, and when. You'll see then we moved on to a development phase of sort of those guiding principles that I showed before in the previous slide. We adapted the consultations we had done, so from those focus groups, from the literature, and from the previous consultations as well. So we already had a lot to work with into some main themes, and realised very quickly they fell into some of the domains or areas, I suppose, that aligned well with the Finding Your Way model, which was developed by Aboriginal and Torres Strait Islander people, particularly David Follant, some of you may know, which was around how to have informed decisions around vaccine during COVID. But essentially there were some similar principles that aligned there. And so we were able to work and adapt from the Finding Your Way model as well. We then had some further focus groups and yarns with people. A lot of this was online, some was face-to-face. It was very iterative. And we went back and forth at this point. So we sort of showed people how things were landing, developed. I won't show you what it looked like then because it wasn't very pretty. But there was about 8 domains that came out, and we would go back and show people and they would scribble all over it and say, no, I don't like this language, get rid of that step. And then we came up with our 6-step model. Then we got, of course, to the testing phase where we did more feedback and refinement of the adapted model. We line tested every word that is included in it, including language. So things that I'll go through that you'll see where we made deliberate changes based on feedback from Aboriginal and Torres Strait Islander people. And we also talked a lot about the look and feel of it. And I hope that you'll get a real sense of that as we go through the documents in a few slides. So it was important to mob that it felt like something that would empower a decision, that it was a positive decision. It wasn't depressing in colour palette, but it also wasn't in your face. So I think we've gotten to a really lovely point with that. And we asked people, which is a kind of a really good proxy for cultural safety measure, about would you recommend using this for your friends and Aboriginal and Torres Strait Islander friends and family. Had some positive feedback through that. And then, of course, the finalisation phase, which was sort of really been in. We refined the model based on that testing phase, submitted the deliverable, and then have had the opportunity to work alongside Nacho whilst the design elements have come through. And here it is. So this is the Making Decisions Together model that you can see on the screen here, which is 6 steps. The idea is that the model is used to yarn with healthcare providers and family about choosing to participate in lung cancer screening. And the model suggests questions you may want to ask, to make a decision, or that your health provider might want to prompt, or that they might want to ask. I've just popped up a quote here from one of our participants when they reflected on how this was coming together. And they say there's nothing in there that mentions any type of jargon, so it's very straightforward, very easy to read. All participants indicated they'd be willing to use the tool in practice or recommend that for themselves, or to recommend to family or friends, which was excellent to receive that feedback at that point. But really, we had that strong confidence in the model's potential to support informed decisions by Aboriginal and Torres Strait Islander people. Interestingly, and I think it goes to the strength of it, lots of people talked about how this model would just be good for any health decision. So whilst it's very specific at this point for lung cancer screening, I think it just goes to show that there was real appetite for these sorts of discussions. And Associate Professor Raglan Maddox, who ran a men's group at one point and was testing this, had an old uncle in there pick it up and take it straight into his GP appointment to do with something else. So that we knew at that point it was going to work well. So these are the resources that have been developed that you can see on the screen. So you'll have, there's 3 at this stage. So you have the participant facing booklet, I suppose. So should I screen for lung cancer? A practitioner guide. So that's for the practitioners to help support the shared decision-making process. And then a postcard, sort of like an A5 size, just to support decision-making, just in a bit of a different mode, a bit more condensed and pocket size. So the practitioner guide, just to go back, is to help support and complement the patient-facing document or the participant-facing document. And really just to support those questions that need to be asked of participants. So it's designed to be used by healthcare providers, so anyone from your authorised medical practitioners, your GPs, to Aboriginal healthcare workers and practitioners, the backbone of the ARCHO sector, but nurses and other allied health staff, which is important. Importantly, I think, just to state too, and I think Jeremy might have stated, the tool is designed for people who've been assessed as eligible to participate. So this is really, this is not a tool to assess eligibility, to have those conversations, though I think there's probably some things that people might be able to use in some of those conversations as well. So I'm just going to spend the remainder of our time just going through each of the steps and talking that through. So the first step is, what are your choices? Interestingly, this started out as what are your options, and we had 4 options, and Aboriginal and Torres Strait Islander people told us very clearly there should just be 2 options: you're participating or you're not right now. We took that on board, of course. So this step involves presenting both of those choices to the participant to make the shared decision making. So of course, the first one being the referral for screening, participating in, that you participate in the lung cancer screening and have a referral for low-dose CT at your radiology service, or not right now. So deferring the decision to participate due to, a range of health or social reasons, or too much else going on, or that they just don't have enough information at that point, or they want to bring back a family member, etc. As I said, these conversations can happen iteratively and may not just happen with one health professional, but importantly, it might be with Aboriginal health worker, or nurses, etc., or family members. So with either of the options, the potential participants should be offered support to stop smoking, with or without participation in lung cancer screening, but to take that opportunity. And of course, that you can take a break, discuss screening with people that's important to them, and return to this decision-making process at a later time and agree on that later time. So the next step was to talk about, well, what are the benefits? So Aboriginal and Torres Strait Islander people who we consulted with spoke really clearly about, especially because it's a new program and because of the impact of lung cancer screening on lung cancer on Aboriginal and Torres Strait Islander people, that the narrative of the benefits of screening was really important. So outlining those are essential, so that people could understand and learn a little bit more about the program as well. So this aim of this step is really to ensure that the potential participant understands that screening provides early detection and the potential for effective treatment. Interestingly, lots of other shared decision-making tools that we looked at, and we showed mob different tools, and they picked out things that they liked or didn't like, focus very much on risks and harms and using that language. Mob told us very clearly that messages had to be positive, strengths-based, but they needed to know the risk, but they should be framed more as what else you should know. So you'll still see risk and harm in there. It's just that it's framed as what else should I know. That was really interesting. And then the third, so what are the next steps? So now that a person knows what the choices are, it's important to yarn with them about what happens next. So if you choose to take lung cancer screening, these are the next steps. So it might talk about the referral for screening and where that might be. So things like, the scan appointment, if there's any out-of-pocket costs in terms of attending, or just to get to the appointment, where the location might be, what happens during the scan, the results, how they be fed back, etc. And of course, smoking cessation. And then importantly, for those that are deferring the scan until later, so they're kind of taking that second option, making a time to revisit the decision, smoking cessation support, of course, and importantly, what happens if someone chooses to wait, and things that they can look out for. So mob were really clear that they wanted to make sure that there was opportunities for people to learn what signs they should look out for, if they've decided that they're not screening at that point. And then this just gives number 4 just gives time and space really for current needs and supports. So a person might discuss with the healthcare provider about what they would need to successfully participate. It just is some prompts here really to have that time and space and discussion, and what supports might be needed. And again, similarly is number 5. So what's important to you? So this step is really about what's important to the participant, which sometimes documenting those things or just talking it through or having the opportunity to share that can help people come to a decision. And then finally, the making a decision and taking action. So really this is kind of the bringing it all together to decide what the best choice is for the person. And there's just a last slide there, or page there that you'll find in the practitioner guide. That's just about re-entry. So that's if someone's started screening and or they're due for a second screen or a subsequent screen, and they might need to revisit some of those steps. You can see, really clearly, I think, from the model that not all patients or potential participants will have to go through each of the steps. Some of my family members would just probably do step 1 and choose and that's it. And then I've got other family members who might feel like they need to go through different parts of this at different time. And I know probably for any clinicians that's sitting in the room thinking this is a lot of time, I think when you have that yarn, you have that space, it might not be as lengthy as you think, or it might happen, and different people, different health care professionals will take different leads on different parts of this. So This is the A5 postcard. As I said, it's just intended to be a briefed version to support and guide conversations. And you can see there for some people that might be enough. You might not need to go through a booklet, but they could have the booklet as well if they need. Really, I know it's a quick scan we've gone through, but I just wanted to sort of take some time to reiterate that, you know, the Making Decisions Together model was developed really intentionally. We spent a lot of time sitting with Aboriginal and Torres Strait Islander people and hearing stories about how lung cancer has impacted their families and communities. Much of our yarns were about how this opportunity is present now to change the narrative about how lung cancer does impact our communities. And they wanted this tool to be able to be there in its fullest extent, noting not everyone will need it in that way, so that people can make an informed decision and have that ownership. We really, you know, from my perspective at Yadjara Wulani, encourage that the use of the model to help guide those conversations, particularly for a new program where there are lots of new things for all of us to learn, to understand what needs and supports are available, that taking a break is a good option when needed, and thinking about who should be in the room is critical. And as I've said a few times, it doesn't just have to be with your doctor or just have to be with a health practitioner or et cetera, et cetera. And I'd really just like to thank each and every person who gave their time and encouragement. Some I know are online today, and also just to acknowledge our team here at Yadjara Wulani, particularly Raglan Maddox, Abby Diaz and Sam Pope, and our governance, Thiru Thame, who provide their cultural oversight and leadership of this work. So I will hand back now, I think, to Sarah, who is going to go through some resources.
Perfect. Thank you so much, Lisa. That was a really great overview of the Making Decisions Together model and the shared decision-making resources that accompany the model, and will hopefully be a really useful tool for healthcare professionals and Aboriginal and Torres Strait Islander people to have those two-way discussions and to make those informed choices about lung cancer screening. We will have time for questions at the end, so Lisa will stay on the line. Thank you, Lisa. And I'll just quickly run through some of the resources that are available, that are coming, and where you can access those resources. So, as Lisa noted, we've got the participant booklet, the practitioner guide, and the participant postcard now available on the NACCHO website. There's a QR code on the slide, and I think there might also be a link in the chat. We are also really keen to promote the resources now that they are available. So if anyone's interested in sharing them through your networks, please reach out after the webinar. I'm happy to share some sort of snippets of information that can help with that. Otherwise, the other resources that are currently available on the NACCHO website are the Getting Ready for Screening checklist. Hopefully most of you have seen that one by now. And also the Smoking History Eligibility Assessment Tool. So that's the proxy approach that NACCHO has developed in consultation with the NACCHO Cancer Expert Working Group and also the Public Health Medical Officer Network. We're really pleased with the response that we've had to that one. It doesn't replace the PACCIE criteria. It just provides sort of a useful guide for clinicians to be able to assess eligibility for the program. And pleasingly, the National Lung Cancer Screening Program guidelines will be updated on the 1st of July and will include a reference to the Smoking History Eligibility Assessment Tool. So that's a big win from the NACCHO Cancer team. The updated guidelines will also include reference to the updated role of nurse practitioners in the program as well. So for those who aren't aware, nurse practitioners are now requesting practitioners under the program. So pending state and territory legislation around imaging requests, nurse practitioners will be able to provide those low-dose CT requests. The other resources that are coming very soon, I know people are patiently waiting for them, are the NACCHO participant resources. We're just waiting on getting the illustrations back from the graphic designers, but those resources will cover things like about the lung cancer screening program, going for a CT scan, and what do my results mean. So I will keep everyone posted as to when those resources will be available, hopefully very soon. But you can scan the QR code that is on the slide to register to be notified when those resources are available. And the other one to just quickly touch on is the RACGP Red Book is being updated to include information about the National Lung Cancer Screening Program, and the 715 Health Check template is also being updated to include lung screening alongside the other national cancer screening programs, which is good. I think that's everything on the slide. Great, moving on. Okay, in terms of promoting the program, we have had a lot of requests for polo shirts, which we love. As soon as we receive the shipment, we will send the polo shirts out. I'm hoping they'll arrive soon. They were ordered quite a while ago. But yes, all affiliates and NACCHA member services will receive polos to help sort of promote lung screening and have those conversations around what screening is. We have also developed some posters to support conversations around screening and just kind of build awareness of the program. The overarching national communications campaign for the National Lung Cancer Screening Program is set to launch in late September. Cancer Council Victoria have been contracted by the department to work on that campaign alongside a consortium of different peak bodies for each of the priority populations. So NACCHA will work with 33 Creative on that campaign. But these resources so the posters and social media tiles that NACCHA is developing in the interim are kind of designed to bridge the gap between now and the national campaign launching in September. We're really keen to hear ideas around what sort of language and messaging you think is going to work with your communities, if there's types of resources that you'd like to see developed. So feel free to pop any ideas in the chat or just reach out after the webinar to have a yarn. We know that you all know what works best with your clients. So yeah, really eager to get some feedback around those. And we will get those posters up onto the NACCHA website ASAP as well, so that you've at least got a digital copy. But the hard copy resources, including for the shared decision-making resources, will be sent to all ARCHOs as soon as the polo shirts arrive. I might wrap up the resource wrap up there and stop sharing my screen. But just wanted to say another big thank you to Lisa and Jeremy, but mostly Lisa, for joining us today and chatting through shared decision making. I will stop sharing, and if anyone's got any questions, feel free to raise your hand. We can unmute people, turn cameras on, etc. I don't know if there's anything in the chat, Lisa or Jeremy, other than some rounds of applause. Okay, what we might do then, I'll give everyone a couple of minutes to just ponder their questions, but thank you so much for joining. We really appreciate everyone taking the time to come and listen and learn about shared decision making and the importance of shared decision making in the context of lung cancer screening, but also more broadly in terms of healthcare decision making. Hopefully everyone's, Joseph's put a link in the chat for the NACCHA Cancer Team email. Reach out anytime. Super happy to have a yarn. And thank you all for sort of engaging in the discussions around lung screening. It's a really exciting opportunity to start to change the narrative around lung cancer in Australia. No questions. You've stunned them, Lisa. Thanks, Shelley. Good question. I will come back to you on that one. We will work out a process to manage requests for resource top-ups. Thanks, Catherine. All right. Thank you very much, everyone. We will wrap it up there.